Our case for today is on cutaneous T cell lymphoma. So coming to the case summary, our index case is a 26-year-old male with no known comorbidities. He presented to our OPD with complaints. He initially presented to a nearby hospital with complaints of papular erythematous eruptions in arms and legs for the past 1.5 years. So in the initial days, he consulted nearby clinics where he was prescribed topical steroids, where he had some partial response where lesions reduced, but it again reappeared. So then he consulted Amala Hospital, where a biopsy was done, which showed a chronic inflammatory lesion rich in eosinophils. Then there he was started on oral steroids. And with oral steroids also, he had initial mild relief of lesions followed by further exacerbation. Then he consulted KMCT, where a rebiopsy showed a primary cutaneous T cell lymphoproliferative disorder, possibly a lymphomatoid papillomatosis with CD30 positive and a CD3 positive. Clinically, he had no palpable lymph nodes, no hepatosplenomegaly, no fever, no B symptoms, anything that is suggestive of a lymphoma. A PET scan done in our hospital was also normal. Peripheral smear done showed no Sézary cells. And slide review at MVRCCRI showed a primary cutaneous CD30 positive T cell lymphoproliferative disorder. So these are his lesions that he's having presently.
So we had received the skin biopsy, which was taken outside as a review slide in our institute. You can see this is a biopsy from skin. We can see the epidermis out here, the squamous epithelium, and below the epithelium is the dermis. Okay, so the dermis appears to be very busy. The upper dermis and the deep dermis, there is something going on in the dermis. However, the subcutaneous fat, whatever is involving the dermis is not involving the subcutaneous fat. Now coming back to the dermis, if I go into a higher power, so there is a lot of cells out here, blue looking cells. Yeah, I'll go to 1 power higher again. So if you can see here, there are many small cells. The small dot-like cells you can see. These are the normal lymphocytes, which looks like a bindi, dark blue. However, there are these large cells also. These cells are definitely large because compared to these cells, the size is quite high. Okay, in addition to the small and large cells, we can see what out here, eosinophils out here. See the pink granular, orangish granular cytoplasm? These are eosinophils. Okay, so we are having eosinophils, we are having lymphocytes. Okay, and these are the histiocytes, some histiocytes. Okay, the background cells, I'll first focus on the background cells. Okay, the background cells, we are seeing a lot of small cells out here. Please forget the large cells out here. These backgrounds are polymorphous. We are seeing different populations of cells, lymphocytes, eosinophils, histiocytes. Okay, now coming on to the main lesion that is blaring at us, these large cells. Okay, these large cells which are seen in the dermis, main part of the lesion, these large cells. Okay, these are large atypical cells. Now, why have I called it atypical? Because of the size. If you see the nuclear membrane, they are irregular. Yeah, the chromatin is not very smooth. It's a kind of coarse chromatin. Okay, so we are seeing these sheets of large cells in infiltrating the dermis as well as upper and deep dermis. And at places, they are showing a bit of epidermotropism. So epidermotropism means the cells are trying to invade into the upper epidermis. So I will try to focus areas where I think on immunohistochemistry slides, the epidermotropism will be a little bit more visible. Might be difficult for the clinicians to appreciate the epidermotropism in H&E. But if you see, these are the atypical cells out here. This is our epidermis, the squamous epithelium, and these cells are trying to go into the epidermis. So there is a little bit of epidermotropism. These atypical cells are infiltrating into the epidermis. So to summarize the H&E slide, so we are seeing a lesion an atypical cells within the dermis and epidermis with a little bit, which are large in size, which are seen in sheets, just trying to infiltrate the epidermis. And what does the background show? The background is polymorphous. The background is composed of eosinophils, small lymphocytes. I think the polymorphism is bit more appreciated in the low power. These small dots, they are the small lymphocytes. In addition, I think the eosinophils we appreciate in high power. So in addition to these large cells, the background is polymorphous. So my H&D diagnosis will be atypical lymphoid proliferation. Now, I will do an IHC to see what are these lymphoid proliferation, whether they are B or T. So my first panel will be a CD3 and CD20. So coming on to the CD20. So this is my CD20. So this is our epidermis. This is our dermis. And the dermis has highlighted some amount of CD20 positive cells. But are these the cells of interest that we are interested in? No, because our cell of interest are quite large size cells. You can see the negative staining here. So these are the large cells which we were interested in. What they have taken up is the small reactive lymphocytes. Okay, so B lymphocytes that's normally seen in any inflammation. So the CD20 is negative in the large atypical cells. Now coming to CD3. So CD3, okay. So it's positive. It's very clearly positive. And as I told you, the epidermotropism is much more appreciable in the immunohistochemistry slides. So if you look here into higher power also, we can see the CD3 has taken up the large cells. See these large cells? In addition, there are some small cells, small T lymphocytes, but the large cells have definitely taken up CD3. So now this is an atypical T cell proliferation. Okay. Now, if you remember our last discussion of NK T cell lymphoma, anything to call atypical on immunohistochemistry, what we look for is the loss of T cell markers. That is, the T cell markers are 2, 3, 5, 7. And in addition to loss of T cell markers, we look whether the 4:8 ratio is skewed. So these two things will tell us in immunohistochemistry whether these cells are atypical. So in morphology, already they are atypical because of the large size, irregular nuclear membrane, the post-chromatin, and the way it is destroying the normal architecture. Now, immunohistochemistry, we have to prove whether they are atypical or not. So this was the CD3 that I have shown you. Now, I would like to see whether there is any loss of T cell marker. So next would be my CD7. So this is my CD7. So CD7, again, we can see the epidermis out here, the dermis here, but the dermis, only very little cells have taken up. And I would like to go into higher power and to see what are the cells that have taken up CD7. So if you see here, the cells are quite small size cells which have taken up CD7. The majority of these large cells are CD7 negative. So I will confirm that the CD7 is negative on the T cells once again by comparing it by CD3. So if you see my CD3 here, they are quite numerous in number. Definitely the T cells have taken up CD3, but where are those CD3 positive cells in CD7? They were normal, they were supposed to take up CD7 also. So the brown color that I see in CD3 is not visible in my CD7 slides. This is my CD7, where only a few cells have taken up CD7. So there is definitely a loss of CD7, which proves that the cells are is atypical. I'm just telling it's atypical. And now I would like to see my 4:8 ratio. So 4, this is my CD4. Okay, again, CD4 is quite brown, highlighted almost all of the cells in the dermis and epidermis. And these cells, again, going to the high power to confirm whether they have taken up the large cells itself. So CD7 shows this very nice membranous staining. All the CD markers will show membranous brown staining. Yeah. So they have taken up in the large cells, almost all of the large cells. So these cells are CD4 positive. Now coming on to CD8. So again, CD8 has taken up similar to our CD7, a few little of cells, small cells, quite small dot-like cells. So they are the reactive cells which have taken up CD8, whereas our large cells, if we go and look in the high power, the large cells, the negative blue cells, which is our cells of interest, these cells are negative for CD8. Now, so there's a definitely skewing of CD4 over CD8. So they are CD4 predominant and CD8 is definitely lost. Now, what about the proliferation index of the cell? For the proliferation index, this is the Ki67, which is a nuclear stain. Okay, it's quite high. It's taken up almost most of the cells. Very high proliferation, no? So the cells are looking very bad, very high proliferation. Not a good sign. But remember, it's a skin biopsy, not a lymph node. Okay, so we have to be very careful in interpreting Ki67. Now, because of the large size, I have put a CD30. So this is a CD30. Okay, CD30 is also quite very strongly positive in almost all of the cells coming into high power. So this is the CD30, which has taken up nice positivity membranous staining in all of the cells. So diffuse strong CD30 positive cells. Okay, so now is it an ALCL? In atypical cells, large size cells. Okay, there is loss of T cell marker for predominant CD30 is diffuse strong positive. So one of the differentials that should come in mind is an ALCL. Okay, so we'll do an ALK. Rule out an ALK positive ALCL. Okay, so this was an ALK stain. The ALK is definitely negative. None of the cells have taken up ALK. Okay, so now with this IHC and histomorphology, what is the diagnosis that we are going to make? So now my diagnosis will depend on what is the history that the clinician or the patient gives me. If the patient or clinician does not give me any history, the diagnosis that I'm going to give is just CD30 positive T cell lymphoproliferative disorder. But in this case, Abhijith had not completely mentioned my report. Yeah, so I had the history, and in addition to that, I had written what could be this lesion in the comment. Okay, so if the clinician does not give me any history, I'm just going to write the CD30 positive T cell lymphoproliferative disorder. It is up to them to decide what are they going to call. Okay, if I'm getting a history that the patient is having a large nodule or a papule or single or multiple nodules, which is increasing in size since the past 4 or 5 months, the duration is quite short. There is ulceration. Yeah. And with this histomorphology and this IHC, my diagnosis is going to be ALK negative ALCL because the 30 was diffuse strong, large cells, abnormal T cells, ALK is negative. I'm going to give it as CD30 positive T cell lymphoproliferative disorder, possibly ALK negative ALCL. Kindly correlate clinically. Yeah, if you are going to give me an history that no, the patient had a long-standing history of patch, plaque, yeah, and some of the nodules, and recently one of these nodules has rapidly growing, and there's ulceration in one of these nodules. Okay, so that means this patient was already a known case of mycosis fungoides. Maybe it was not diagnosed clinically. He has neglected that lesions, but there is a definite history of a patch and plaque, and it is these patches and plaques are seen in the sun protected areas like the proximal extremities, the trunk, the buttocks. Okay, so that means that the patient is already known case of mycosis fungoid, and now recently one of the nodules is showing alarming features, and you've taken a biopsy of the nodule. And I'm seeing the same morphology, the exact same IHC, sheets of CD30 positive T cells, then my diagnosis is going to be a large cell transformation in mycosis fungoides. Okay, now the history in this patient, if we go back and take the history correctly, the history is a little bit not exactly as Abhijith had told. There's a little bit alteration in the history. If you go back to the patient ask, the patient gives a history, typical history, that these lesions, I'll go back to the image and show you the images. Just let me just share one of the images. Yeah. Okay, so in this patient, as Abhijith had shown the images, so this is a crops of papules or nodules. Okay, papule is less than 1 centimeter, nodule is more than 1 centimeter.
Excuse me, ma'am.
You said that only from the history you can tell whether it is mycosis with a recent transformation or whether it's a ALCL, right?
Yes, sir. Yes, sir.
But mycosis isn't the pathology itself totally different because I thought you get epidermoprofesum in mycosis. Here, mainly the dermis is involved.
Yes, sir. That is a classic mycosis fungoid, which does not show any large cell transformation. There are different phases. The initial phase will have just cells tagging along the epidermis without much cells in the dermis. But in later stage, you might see in the dermis and epidermis. But in those normal cases of mycosis fungoid, we won't see sheets of large cells. Okay. The histomorphology, that is, this is a very clear case where the shows the importance of history. So in mycosis fungoid can have different histomorphological appearance based on what stage these have been biopsied. Have I answered your question, sir?
Okay.
Yeah. Any other questions? Can I proceed? Abhijith?
Yes, ma'am.
Yeah. So in this patient, the history was crops of papules and nodules. Okay, and if you see here, it's in crops. You see, rest of the arm is okay. Here also you see it's in crops. And in addition, you see these here, these are the regressed papules and nodules which have regressed. Okay, and he gives a typical history that these papules and nodules come after some time, they regress by itself, but in between there is a confounding history of some steroid application. So that is making a little bit confusion in the history. But otherwise, if you take a detailed history and ask once again and again, these crops of papules and nodules seems to come by itself and go by itself. See, these are the areas where the regressed papules are seen. So in this, it's photo, we can see different stages of the lesion. Some of them have regressed, some of them is on the progression with some ulceration, some of them is on the progression of regression, on the stage of regression. So this is a very, very classic history of the entity called as lymphomatoid papulosis. So in this slide, with this morphology and with this IHC, if you're giving me this history, and if I'm seeing this lesions, then my diagnosis is going to be CD30 positive lymphoproliferative disorder, possibly lymphomatoid papulosis. Okay, so this shows the importance of history in making a diagnosis in pathology. So a good dermatological coming back, lymphomatoid papulosis can have different morphology. So as Sridharan sir had told, see, mycosis fungoid, epidermotrophism would be seen. It is actually different stages of the lesion will show different H&D images. So similarly in lymphomatoid papulosis also, the different lesions, if you biopsy, you will get different morphology. And also, there are different types of lymphomatoid papulosis also, starting from A, B, C, D, E, and lymphomatoid papulosis with DUSK22 locus. So now, if you ask me what is the importance of the subtypes, I will say there is no importance. No prognostic importance, nothing. But the importance of identifying the subtype is that you don't misdiagnose it as something else. Yeah, if you see the type A, which is the most common type of lymphomatoid papulosis, has a morphology which looks like exactly like a Hodgkin lymphoma. You will see scattered large cells which are CD30 positive amongst dense polymorphous inflammation. So in that case, if you are not knowing that, okay, lymphomatoid papulosis can also look like this, yeah, we will not be able to make the diagnosis. And remember, Hodgkin lymphoma will never involve the skin. Isolated skin Hodgkin lymphoma is never seen. So if you're going to make a diagnosis of Hodgkin lymphoma in skin, there is definitely going to be some node somewhere, or else the diagnosis is most probably something else. Yeah. So and if you see the differential, one of the differential of type A is mycosis fungoid tumor stage. So it is a tumor stage because we are seeing only isolated CD30 positive cells scattered here and there. They are not seen in sheets. And if the patient has a history, so here the discriminating feature, if you see the only discriminating feature, this is not the histomorphology is the same, the IHC is exactly same. The only discriminating feature between this mycosis fungoid and MF, and lymphomatoid papulosis is the history. The clinical evolution with preceding patch and plaque, then I will make a diagnosis of mycosis fungoid. Yeah, if it is a cutaneous ALCL, then there will be a rapidly growing large tumor or multifocal nodules. Yeah, there won't be history of regression by itself. So that, but again, the history is the IHC is the same, the histomorphology is exactly the same. Now coming to type B lymphomatoid papulosis, there we will see the epidermotropic infiltrate, more of epidermotropic infiltrate and less of dermis inflammation. It will be exactly like a mycosis fungoid, dominantly epidermotropic, small atypical cells and cerebriform cells. And IHC will be also exactly the same. Only thing that is differentiating is just the history. Okay. And now our mycosis fungoid is type C, which is similar to a cutaneous ALCL, where you are seeing monotones infiltrate and sheets of large of CD30 positive cells and few inflammatory cells. Okay. So here the differential definitely was cutaneous ALCL, but the history was not matching with that of the ALCL. history was that of a lymphomatoid papulosis. Again, one of the differential would be large cell transformational mycosis fungoid, provided if the patient had a history of preceding patch and plaque in sun-protected areas. Okay, now coming on to D, where it mimics a cutaneous aggressive epidermotrophic cytotoxic T cell. But in this D, the cells will be CD8 predominant. So a lymphomatoid papulosis can be a CD8 predominant cell also. It need not always be CD4 predominant. Okay, if you see CD8 predominant, CD30 positive cells with these morphology, one of the differential is going to be a cutaneous CD8 positive epidermotrophic cytotoxic T cell lymphoma. Yeah. But the history, what would be the history saying? It will be rapidly, very, very short duration, rapidly evolving ulcerated or erosive plaques and nodules would be there in the history. Yeah. Again, in type E would mimic a NK T cell lymphoma, extranodal or cutaneous gamma delta T cell lymphoma. Again, they are going to be CD8 positive cells, not CD4 positive. Okay, and then there you have to again go back to the imaging. You will have to do a PET, see whether nasopharynx there is any tumor. You can do an e-burish. Okay, and a history is very important. And there is another subtype called as lymphomatoid papulosis with dust stimulated locus rearrangement. Okay, that will mimic a mycosis fungoides tumor stage and large cell transformation. Now, just to reinforce the fact why the history is important, this lady had come to our institute 4 or 5 months back. Okay, this was the lesion that was seen in this lady. We are seeing just 2 lesions were there on the face, which was rapidly growing. There was some sort of ulceration, and I just show the superficially the slides of those ladies.
One more doubt is there, huh?
Yes.
No, because I fully agree with you that you need a good clinical history and examination to make a diagnosis. My doubt is a systemic ALCL with
Yes,
cutaneous involvement versus cutaneous ALCL. Can you differentiate based on pathology alone, or do you always need history and imaging?
No, sir. In systemic ASL, if it is involving the skin, almost 90 to 95% of the time, there will be ALK positive. So we are being taught that whenever you get a skin biopsy and you are getting an ALK positive ALCL, most of the time, the patient is going to have a node. Do a PET and see whether there is a node. And only after you rule out there is no node or node involvement, you can give out an ALK negative ALCL. ALK positive ALCL. So if it is a nodal ALCL involving the skin, they will be most probably ALK positive. Skin ALCLs are usually ALK negative and they are having a very good prognosis. So these were the slides of that patient. So we had seen the clinical picture. It was not like that what we had in this case. Okay, and here also we are seeing some epidermis. Yeah, epidermis is here. There's epidermis. There's some sort of ulceration over the epidermis out here. There's some sort of busy dermis, and these cells have seemed to ulcerate the overlying epidermis. Okay. In the dermis, again we are seeing sheets of large cells. These sheets of large cells. And in addition to the large cells, again, there are this background is a little bit polymorphous, not as much as that we have seen the previous case, but definitely there is, I try to see some of the, some of the lymphocytes and neutrophils. So there are these small lymphocytes in the background. Okay, and then there are these large cells. Some of them are looking like fortune-like cells with prominent nucleoli. However, there are these large cells and there are these small cells. So there are sheets of large cells in polymorphous background. Okay. And CD3, this was also an SOH case. By the time we had got this case, the section was so much depleted. So hardly any of the tumor cells were left. But whatever the tumor cell was left was definitely CD3 positive. So if you see, these large cells are CD3 positive. What about CD7? Large cells are, these are the large cells which are CD7 negative. Similar to our previous case, Sheets of large cells, CD3 positive, CD7 negative. What about the CD30? So this is CD30. Again, diffuse sheets of CD30 positive cells in the dermis involving the epidermis, infiltrating the epidermis. So it's going and involving, this is the epidermis here, going, has ulcerated. But if you, I'm sure if you go into the section, there is definitely epidermotropism. So, but in this case, am I going to make a diagnosis of lymphomatoid papulosis? No, because the clinical picture is this. Okay, in this case also it was ALK negative. So exact histomorphology, exact immunohistochemistry, but the clinical picture is different. And I'm seeing large tumor like nodules coming and it's ulcerating, rapidly growing. So the diagnosis that I gave again is CD30 positive T lymphoproliferative disorder, possibly ALK negative ALCL. Okay, so this is the importance of history in dermatopathology. Okay, so CD30, if you whenever you see sheets of CD30 positive cells, the differentials that should come into our mind would be lymphomatoid papulosis, ALCL. Okay, large cell transformation of mycosis fungoides and some cases of more folliculotropic mycosis fungoid, aggressive cutaneous lymphomas, if it is CD8 predominant cells, even viral infection, arthropod reactions, KBs, pseudolymphomas can show sheets of CD30 positive lymphoproliferative disorder. So the CD30 positive T cell lymphoproliferative is the second most common T cell lymphomas following mycosis fungoid. It includes lymphomatoid papulosis as well as ALK negative ALCL. Both of them are supposed to have excellent prognosis. The significance is that these lesions have increased risk of secondary cutaneous lymphomas. Like they can progress into a mycosis fungoid or cutaneous ALCL, may precede, be associated or follow a lymphomatoid papulosis. Also have increased risk of non-hematological malignancies like squamous cell carcinoma, melanoma, etc. Hence, it's a long-term follow-up is advised due to increased risk of association with lymphomas. Yeah, thank you. Abhijith, you can take over.
So I have prepared a presentation of cutaneous T-cell lymphomas. It's a little extensive, so we'll stick on to our index case. So cutaneous T-cell lymphoma accounts for 70% of all primary cutaneous lymphomas. So this is the WHO EORTC 2018 classification. So cutaneous T-cell and lymphomas are classified into mycosis fungoides, MF variant, Sézary syndrome, adult T-cell leukemia, and as our index case, primary cutaneous CD30 positive lymphoproliferative disorders, which has primary cutaneous ALCL and lymphomatoid papulosis. So coming to the CTCL, it can be clinically divided into indolent and aggressive CTCLs. Indolent includes mycosis fungoides, primary cutaneous ALCL, lymphomatoid papulosis, subcutaneous panniculitis-like, and primary CD4 positive small medium pleomorphic lymphomas. And aggressive subtypes are Sézary syndrome, NK or T cell nasal type, primary cutaneous gamma delta T cell lymphoma, primary cutaneous CD8 positive cutaneous T cell lymphoma, and primary cutaneous peripheral T cell lymphomas unspecified. So CTCL represents less than 4% of all non-Hodgkin's lymphoma. Clinically, they present as erythema, papules, patches, plaques, nodules, or even tumors. So coming to the prognosis in general, early stage disease has a 10-year overall survival ranging from 50 to 90%, depending on the subtype. And advanced stage diseases, they have a poorer prognosis with a 10-year overall survival ranging from 15 to 53%. So these are the clinical features of various types of T-cell lymphoma, just Dr. Ann has presented in her PowerPoint. So coming to the workup, we need a complete physical examination, including determination of the type of skin lesions, identification of any palpable lymph nodes, and to look for any organomegaly. Skin biopsy should be taken from the most indurated area if we are taking only one biopsy, and routine histology and immunophenotyping has to be done, and evaluation for clonality of T-cell receptor gene rearrangement has to be done. So blood test, Dr. Ann has mentioned in her presentation, and radiology, here we have done a FDG PET, which is more than enough. So I'll directly go to the management of our index case. Otherwise, it will be a little bit difficult to complete it. So these are subdivided into primary cutaneous ALCL and lymphomatoid papulosis. And coming to the prognosis of each, cutaneous ALCL has a 10-year overall survival rate of 90%. When it comes to lymphomatoid papulosis, it's almost 100%. So the subtypes of LP, Dr. Ann has described in detail, so I'm not going into it. So coming to the management part, lymphomatoid papulosis is a recurrent self-healing papillonecrotic or papillonodular skin lesions. First thing we have to tell the patient is that there is no curative therapy. There can be cosmetically disturbing numerous lesions where we can give some form of treatments. So when we are getting this kind of patients in OPD, first thing you have to tell them is that the disease has a chronic course of years to decades of recurrent papillonodular lesions that undergo spontaneous regression after weeks or months. That is there in history of our patients. So none of the available treatment modalities alters the natural history or reduces the risk of development of lymphoma and lymphomatoid papulosis. As ma'am mentioned in C and D subtype, it's almost 10% risk for progressing into lymphoma. So when we clinically categorize the patient, if it's a limited asymptomatic disease, for example, if the lesions are in non-cosmetic areas like not on the face or on the hands, we can actually go for a wait and see strategy. Depending upon the patient preference, we should also communicate it to the patient. So if the patient desires an attempt to minimize these lesions, that is a limited asymptomatic disease, we can advise for a super high potency topical corticosteroids. This includes betamethasone dipropionate, clobetasol, difluorocortisone, fluosinonide, and fluorantranolide. I don't know what all are available in India. So skin lesions more than 2 centimeters that do not regress spontaneously in 8 weeks, that should be biopsied to exclude primary cutaneous ALCL. So coming to patients with extensive or symptomatic disease, two treatment options are there. One is weekly low-dose methotrexate. So we have the dosing is 5 to 35 mg per week, oral or subcutaneous administration. We usually start with 5 to 10 mg per week and increase it by 2.5 to 5 mg per week as tolerated to a maximum dose of 25 to 35 mg per week if there is no clinical improvement. And patients receiving weekly methotrexate, we should give folic acid along with it. And as I said, it has a chronic so maintenance therapy is usually required. So how we give maintenance therapy is like we gradually decrease the dose once we get a complete or partial response. So we decrease it by 2.5 to 5 mg per week, and we should continue it at the lowest effective dose. So the duration of treatment or maintenance treatment is based upon clinical response. There is no cutoff guidelines for it. So another option for treatment of patients with extensive or asymptomatic disease is phototherapy. So we have to give soralin with ultraviolet A therapy who does not respond to weekly methotrexate. So this has to be administered twice weekly for 6 to 8 weeks until clearance. Then as a maintenance therapy, you have to undergo 1 session per week to prevent relapses. Alternative to soralin is narrowband ultraviolet B phototherapy or ultraviolet A1 phototherapy. So other treatment options, there is no evidence for this, just based on case series and reports are oral topical retinoids like bexarotene, topical meclorethamine or carmazine, brentuximab vedotin, or low-dose methotrexate plus interferon alpha in lymphomatoid papulosis with Th17 phenotype. Coming to the management of primary cutaneous ALCL, it usually presents as like ma'am mentioned, a solitary or localized. We have seen that case in her presentation, ulcerating tumors or nodules. So localized disease, we have to give surgical excision or radiotherapy, and complete spontaneous remission. If it's there, no further therapy is required. If it's a multifocal or relapsing lesions, we have to give low-dose methotrexate, just as we mentioned in lymphomatoid papulosis, and radiotherapy can be given for new lesions. Regarding brentuximab vedotin, we have a phase 3 trial results showing an overall response rate of 75% and a complete response rate of 31% with brentuximab vedotin. This is indicated for refractory refractory lesions with extracutaneous disease. And chemotherapy is also reserved for extracutaneous disease. So this is regarding the management of CD30 positive T-cell lymphomas.